And I'm going to talk about the changing ICU landscape in Uganda. I'm going to talk about the origins of the ICU registry, and also going to talk about some of the achievements. So many of you will probably know this better than me. I can hear it echo. Let me turn the volume on here down. The audio visuals are slightly off-putting. Okay, so 10 years ago or 12 years ago, we had very few intensive care units in the country. There was a paper that was published in 2012 by a colleague of ours, Arthur Quizera, and some other colleagues, that showed we had about one functional ICU bed per million population. Only a quarter of those beds were in public hospitals, and there were only really 3 intensivists. The ICUs that were there were run by anesthesiologists, with some ICU nurses, but only 5% of them were formally trained, and our mortality at that point from that study was 40%. So then the next paper that was published came in 2020, led by patients at Mania, which again described the ICU landscape in the country, and it hadn't changed a huge amount. There were 12 functional ICUs, so a few more functional ICUs, but Uganda's population had increased, and so we still only had 1 bed per million population. Still only a quarter of them were in public hospitals, and although we had a few more intensive care specialists, and we had a few more nurses working in the intensive care units, we still had only a very small proportion of nurses who were formally trained. And then, of course, COVID came. And COVID came with its challenges that we will all remember, because people around the world always try and do the right thing. They like to support care, but it's not always helpful. And so what you think we need maybe not what we actually need. But I think the COVID pandemic had a silver lining, and it really focused the country on the need to improve critical care services. And so there was some work that was done, again by similar names, colleagues that you recognize, that looked at how we can expand critical care capacity across the country. And it looked at all of the different building blocks of what critical care services would need. But unfortunately, building a service like this takes a long time, and there's often this idea that if you put equipment in a place, then suddenly you'll have a service. And we all know, so every regional referral hospital was given a lot of equipment during the COVID pandemic. ICUs were created, in inverted commas, but they weren't actually functional ICUs. But I think the point is that the messaging started to change, and people started to talk about critical care. People started to realize that we needed critical care, and so that's very important. And the numbers of intensive care units in the country have continued to grow. And this is data from Cornell. 25 ICUs. The numbers of ICUs are doubling, which is great. And there's been a big increase in both the number of public and private ICUs, particularly in private ICUs. And it's supported by capacity strengthening in other areas. And so oxygen is a good example of this. The country now has much better oxygen systems, which of course allows us to deliver critical care much more easily. There are still quite a lot of work to do. You can see that all of our regional referral hospitals, many of them still don't have functional intensive care units. But it doesn't matter how many, how much equipment you have. It doesn't matter all the resources. If you don't know what to do with it, or you don't know where the gaps are, then it's going to be very difficult to improve. And so there were big gaps in our knowledge and understanding of the epidemiology of critical illness, the processes of care that were happening in the country, the resources we have and how they're being utilized, and then what happens to our patients. And so this is where we were able to identify that data was a big gap. And if we were able to implement a registry for ICU patients, then it would be another cog in the wheel, and it would allow us to understand more about critical care and how we can improve. So the aim was to establish a national cloud-based registry that can be used at a facility and national level to understand and improve the quality of care for our patients. And Cornell has shown you this picture before. I think this is important for us just to focus on, because a registry platform is an incredibly powerful platform that can be used for very many things. And I'm going to talk in a bit about its primary role, which of course is for us to understand and improve care in our ICUs. That's for you to understand and improve your care. So it's primarily for quality improvement, but it can be used to support very many other activities. Clinical trials, benchmarking, research, policy decision making, all of those different aspects. So how did it start? Well, we started asking some questions, and of course when you want to do something but you're not sure how to do it, you ask for some help. And you'll see these names come up several times. So Abby and Rashan were the original team that guided us on how we could set up a registry, and they are the leads of the wider Critical Care Africa Asia network, which I'll talk about in a moment. But we wouldn't be where we are now if we didn't have the support from our colleagues and the entire network team that you don't see apart from occasionally on the calls, the monthly calls. The Critical Care Africa Asia network is a network of intensive care registries across the 2 continents, and it's a huge network, and it supports each other. The 18 different countries, we all use very similar or the same ICU registry platform. We can learn from each other, and when you hopefully later when we hear from the Kenyan registry, you'll realize, but very many of the registry platforms have similar challenges that we have, similar successes, and you can really learn from other colleagues across different countries and different networks. And so we were lucky to be included in the Critical Care Africa Asia network and get the support to set up our own registry. So we started in 2020. We actually started, I'm proud to say we started in Mbali, just with a pilot in 2020. Now there are quite strict data protection laws in Uganda, so we were insistent at the beginning that we needed to have the data stored and hosted here in Uganda. And luckily the registry platform is designed in a way that has security and data protection in mind. So all of you can log in using your own login details, and you can access the data from your registry, and you can benchmark that against the whole of the registry in Uganda, but you can't access somebody else's data, and that's very important. So data ownership belongs to each ICU, and as Cornell said, you can, hopefully you have already been using it and you can do what you want. So the model that we started with is that every ICU has a lead, and then it chooses some data entrants. We could have a discussion here about the model of data entry and how successful it is using nursing staff who are in the ICU already versus using a data entrant, and there of course are pros and cons of both approaches, but the system that we have seems to work reasonably well. And then of course we have our central team that provides the ICU, the IT support for all of the sites. So I wanted to just briefly mention this because it's going to inform the next slide when I talk about approvals, but the core or primary goal of the registry is for us to help improve quality of care, and so these are metrics that the registry automatically collects when you put the data in, of course, but metrics on different aspects of our ICU care that you're very familiar with. that if we do them well, then our outcomes of our patients improve. And these care processes and quality of care impacts are things that the registry is designed to support us to understand and use to improve the quality of care. So why is that important? Well, it's quite tricky to get approval for some of these things in Uganda. And so we do two things. The first is that the registry platform has approval as a quality of care registry. It's registered and approved by the SBS REC. We use the data as part of routine care to improve the care. We have a waiver of consent, and that means we renew it every year. It's registered with the UNCST, and it allows the registry platform to continue for that purpose. But because it's so powerful and it can support registry embedded research, we have to be careful that the necessary approvals are in place when we want to do research projects. And so every research project that you hear about today undergoes its own separate research and ethics approval process and has its administrative approvals from each site. So there's almost like a two-tiered approach to approvals: the underlying registry approval, and then any research that's going to take place has to have its own separate review. And that helps to ensure that our participants are kept safe, and it also helps to ensure that our data is protected. So how have we grown over the years? We started in 2020 with one site, piloting for a couple of months. And then at the beginning of 2021, we had two ICUs from Malago join in, and Mbarara and Lubaga. And so we ran for the first year or so with those 5 sites. And then we started to grow, and we have added 7 sites came on board in 2023. And then when Cornell started the Motivate study, we added some more sites. And you can see that in the last 2025 and in 2026, we've also added 3 more sites in both of those years. And so we now have 24 sites, which is almost every ICU in the country. Not quite, but almost. And I think it's astonishing that in the last 12 months, almost 4,000 patients have been entered in the registry. That's a huge number. And over the course of the registry, we've had more than 10,000 patients in total. So what have the outputs been? Now, I think this is the bit where we've not done very well, and perhaps we need to get better at. And that's describing how we have actually used the registry to improve the quality of care in some of our sites. I know that it happens, and hopefully we'll hear 1 or 2 stories later about how the registry data is being used. But I think we're not very good at just talking about that underlying process where we can use the registry platform, and it is used by the different hospitals to improve quality of care. It's much easier for us to talk about those outputs that everybody sees. And we've really, I've split these into 4 different categories, and they're changing all the time. There are some manuscripts that have been submitted or have already been published. We've also been involved in several network-wide studies, and you're going to hear about this later. But I think on the right-hand side of the slides, there are a couple of other aspects of the registry platform which I think are also incredibly powerful. It supports our postgraduate training, some of the MEd theses for our students. I don't quite believe in MEd training forcing our residents to do research, because it takes a lot of effort, and most of them go on and become clinical anesthesiologists rather than academics. Many of them end up not finishing because the research becomes so burdensome. So the registry platform gives us a forum that allows them to do good quality research that can hopefully have an impact, and yet the burden of data collection and running your own research project is reduced a little bit. So that's perhaps an unintended benefit of the registry platform. And then also we have links into the Ministry of Health. We have always been supported by the Ministry of Health for this. And so we were able to use some of the data to go into the policy and planning for scaling up and improving critical and surgical care in the country. And so that's also a powerful output. Now, Cornell asked me to talk about, I was going to just mention this inclusive authorship approach. I think it's important that we hopefully all know this, but I believe strongly, and I think all of us believe strongly, that everybody who contributes to the registry should benefit from the outputs that come out. And so in all of our publications that come from the registry, if you have contributed to the project itself, and data collection or data entry is one component of that, and you review the manuscript and you contribute to it, then you are always included in the authorship. And so very many of you will have opportunities to be involved in publications over the years. And I think that's a very important approach for us and for the success of the registry. So Cornell was talking, I think he was hoping that I would come up with some new projects that will fund the registry for the next 10 years. Unfortunately, I don't yet have I don't have any of those in my pockets. The future of the funding is in all of our hands. Maybe I shouldn't say it's in your hands, because it's also in my hands. We're all in this together. The registry platform is not going anywhere. The ICU registry will continue. We don't have funding after 2026 to pay for all the data entrance. But hopefully we have a room full of 60 motivated people who understand the benefit of the registry, and we will want to collectively continue as we look for ways of supporting the costs that have to be met to keep it going. But certainly the registry platform is not going away. I think one thing that we perhaps could do better is still this idea of how we use our data. I would be interested to know, of all the sites, how many of you meet every 6 months and talk about your data, or every 3 months and talk about your data, or have a monthly QI meeting where you look at some of those quality metrics. I'm sure it's not all of us, and yet the data is there. And so I think that's definitely one thing that we can do better, is to strengthen how we use our data, to regularly improve the quality of our care. And we need to turn all this evidence that you're going to hear today, all this information that you're going to be told, these new things that we're finding out, we need to use that data to change practice. And I think that's the challenge, the gauntlet that's being laid down now, when Cornell talks about the Motivate findings, or when Brian talks about ICOPE, the out-of-pocket expenditure. How are we going to use these results so that we can actually change and improve ICU care in the country? So I am also going to end on my slide with some extra acknowledgements, because actually we are incredibly proud to say that the Association of Anesthesiologists supports the ICU registry, and without the association we wouldn't have the registry platform, and we haven't yet mentioned it, so thank you to the association and the entire team. As Cornell said, the entire team that makes up the ICU registry, the data entrants, the site leads, our steering committee, and the wider Critical Care Africa Asia network. And it's the technical support team that helps our work. So let me end there. Thank you.